Well, thank you for allowing me to present our experience of the last 8 years of doing ablations on liver with focus ultrasound guided. Well, this is our experience with the two devices. The one that you see at the very right is the old JC200. And recently we have acquired JC, which is this device that it's probably less cumbersome, more useful, and with a better quality of image to follow the treatment. This is, you see here, the whole device and the transducer. So we have in our unit of focus ultrasound oncology ablation, we have done more than 200 cases from 2010. With basic more than 50 cases of liver tumors, primary and metastatic, and around 80 cases of pancreatic. The rest are tumors of soft tissue. And what we're going to explain now is our experience on the liver. This is an example of the type of tumors that we treat, because we have to emphasize here that we're not going to do treatments on patients that are doable by normal ablation modalities like radiofrequency or embolization. Those modalities take 20 minutes or 30 minutes as most, and these ablations, when we do a focus ultrasound, is more cumbersome. We have to place the patient, we have to make all the treatments, and it's a more cumbersome and longer procedure. So, well, these are the characteristics of the patients that we have treated. We have 25% of hepatocellular carcinomas, 75% of liver metastases, and most of the patients doing also chemotherapy and other conventional treatments. These are the results. Basically, treatments timings are between 60 and so between 1 and 3 hours. So difficulties are related to the patient positioning. Most of the patients we're doing on the position on the right side, so through the ribs to the rib cage, and this is what we see here. So we see the shadow of the ribs and the ablation here inside with this image of the sonication with the response. So we think that we can obtain good ablations when the tumors are very deep, when the tumors are more difficult, when the tumors are close to the vena cava, and this is what we do and where we reserve this type of ablation for these patients. So when we are going to do it, we do it. It's easy at this point to obtain the ablation, or to obtain not a full ablation but a partial ablation. And complications mainly are local complications. We had complications in terms of costal osteonecrosis in cases that we've done longer procedures or 2 or 3 procedures separated by weeks in patients that were on demand of that. This is some examples. For instance, this is a lesion that is close to this. Excuse me. This is a lesion that's close to this. It's placed on this tube, and this is the ablation obtained. This is something that we can do basically with this type of ablation. This is another case. This is a patient with an hepatocellular carcinoma 8 centimeters long that was discarded for treatment, discarded for surgery, discarded for chemotherapy. And we did 3 ablations, and here we see the tumor markers, the alpha-fetoprotein going down. The patient now is about to be 5 years of survival. Another case with this huge tumor and the treatment between the ribs. This is another very interesting case. We see 3 tumors here. One on segment 4, another on segment 2, close to the vena cava, and another on segment 6-7. And because of the position, we were able to treat in a row the 3 tumors. Here we're seeing the tumor treated in segment 2, close to the vena cava, and here we're doing this tumor, segment 7, also between the ribs. This is another case when we do the treatment between the ribs, and that is the ablation. You see here the video how we do it. And when we approach the image, we see this white, beautiful response of the ablation obtained. Another case, this is another longer case, and you see here on the left the numbers, the number of sections that we have to do to treat the whole tumor. And how is performed the ablation when we approach and we see how the response is done. So in conclusion, focused ultrasound HIFU an effective and safe interventional oncology ablation for malignant primary and metastatic hepatic tumors. In liver tumors, difficulties related to available devices make it too cumbersome for accessible lesions. At present, compared with other ablations, and access to deep lesions shows an opportunity for this system to increase the possibilities of use with this type of ablation. And I want to thank the team and the nurses and all the people that allows me to be here presenting to you and enjoying this beautiful city of Reston and Washington, D.C. while they're keeping the house clean. Thank you.
Thank you. Are there any questions? If someone.
For the case of the skin burn, do you know why? Was there anything specific about either that patient or the way that they were treated that might have led to the skin burn?
The skin necrosis that we have a problem when we stay longer periods of time doing that. One is that there is a reflection between the rib and the skin. And because we try to minimize the sonication between the ribs, but there is always a little bit of heat that it's taken by the ribs, and it makes like a mirror effect. And then we have all the subcutaneous fat with edema. And in some cases, in this case, we had after the third procedure necrosis of the rib. It was due to the procedure.
Yes.
Well, very good presentation. Do you anesthetize this patient or sedation, or how do you?
Full anesthesia. We anesthetize those patients, and we want them to sleep because it's a longer period of time, 3 hours, and the position is very, very uncomfortable. And just because of that, we prefer to have the patients. And because when you treat between the ribs, you hit the intercostal nerves, and that hurts.
What about the respiration in terms of the movement and things like that? Because
we see what we're doing, and sometimes you have to wait until the lesion appears from behind the rib, and then you shoot. So, and sometimes you do apneas to treat the remains. And in some cases, you cannot treat behind the rib because there's no way that by the respiration you can move the lesion behind that. But we're playing with that.
Thank you.
Yeah, one more question?
Yeah, I'm just a little interested. How did you find the tumor volume before treatment? Is it on the ultrasound image, or have you got a CT or an MRI before?
Yes, we have a CT, and I showed in one of the, let's see, if I can go behind.
And then second part to this was...
You see this? This is the MRI, the CT,
Sure,
and this
sure.
is what we see. So what we do here is a fusion image that is done in my brain. So
Yeah, and when you treat, as you know, as you illustrated very nicely in this image, it becomes hyperechoic, so it's white.
Yeah.
Do you treat from the deepest part to the most superficial so that you can continually see this? Because if you start at the front, you can't see the back, right?
well, what I normally do, I start from the middle, and then I go one back and one forth, one back and one forth, one back, and
A bit
then.
of both. Good.
All right. Thank you very much.
Thank you.